Welcome. This is an informal press briefing being held at the 21st International AIDS Conference here in Durban, South Africa. The focus of this press briefing is on the super fast track for children and the faith-based involvement in this super fast track. The HIV response is intense, and the 18,000 people who are here at the International AIDS Conference are focusing on ways to intensify our response over the next few years, with the hope that by 2030 we can eradicate AIDS as a public health threat. With me today are four people who are particularly involved in treatment issues, in responding to the issues of children living with HIV or at risk of transmission, HIV transmission. I have to my immediate left, Chip Lyons, who's president and CEO of the Elizabeth Glaser Pediatric AIDS Foundation. Stuart Kean, senior policy advisor, World Vision International. Astrid Berner-Rodoreda, who's an HIV policy advisor at Bratsch de Welt in Germany. And Msgr Robert Vitillo, who's the Secretary General of the International Catholic Migration Commission. So I will address some questions to the panel for a discussion and then open it up to questions from here or questions that might come in from those who are watching this online. And I think I will address my first question to you, Stuart. This morning, Ban Ki-moon, the UN Secretary General, in a press briefing here, highlighted the importance of responding to children in the HIV response. But we also hear about all the challenges to reach treatment for adults and the need for fast track. So why do children need a super fast track?
Okay. No, I mean, it's a good question. I think it's not that adults don't need a fast track, but I think the issue for children is that it's important to understand the shocking fact that 50% of those babies and infants who are living with HIV will die by the age of 2. And at the moment, we're only really managing to test and diagnose around 60% of those whose mothers we know are living with HIV. So there's a lot of children who we're not even diagnosing. And in terms of treatment, we're about 49%. So only half of those children are actually on treatment. And so unless we reach, 50% of those are not on treatment, will die. Now, the excellent news was that last month, the member state governments of the United Nations agreed to a very ambitious target to get 1.6 million children on treatment by 2018. So that's 2 years from now. Now, that's doubling the number of children on treatment. Now, we can't do that without a super fast track. The ambitious target requires that we really make efforts that are superhuman, and we have really got to do all that we can. And so the term super fast track, I think, is worthy of the name. But I'm not saying that the goal of 90-90-90 is not important for all adults as well. It is critical.
Chip, could you explain a little bit more about this super fast track? I mean, how is it really going to be implemented in terms of the partnerships, and what is it really going to be achieving?
Sure. Thanks for asking. Thanks for including me. What Stuart is saying is absolutely right. By just sort of business as usual was leaving kids behind. The fact that we're at half the kids having access to treatment is a huge improvement on just, say, 3, 4, 5 years ago. So day in, day out, frankly, kids largely get left behind, not necessarily intentionally, but by virtue of how services are run, the lack of testing, and so that the families and the children know their status, the lack of proper medicines for kids. There are a number of factors. It's not negligence. It's not that people don't like kids. But the facts are the facts. If we don't do something differently, better, faster for kids, we're going to lose those kids. And the mortality rates are huge, as Stuart already said. So The notion is pretty simple. We're starting at a relatively low level of coverage. There's no question that we can dramatically improve by what we do and with whom we do it, the number of kids that are on treatment. It's morally repugnant to have the tools and the ability to deliver them and not deliver them. And yet, as I said, business as usual is not good enough. So that's what behind the super fast track. It's a strategy of UNAIDS. Frankly, it's a strategy of UNAIDS that has been improved and advanced and made even more practical by virtue of the voices of the faith community. The experience in the field, but also the perspectives coming from consultations in Rome and other places. Also, the document that Stuart spoke of, the political declaration that was approved at the high-level meeting a month ago or 6 weeks ago, that draft document 4 months ago was not good for kids. It was not good enough. And by virtue of a lot of voices, a lot of effort, faith community and others, that document is actually a better document for kids than any other political document that's been approved by member states on HIV and children. And so you raise your voice, you bring evidence of what you know how to do, you demonstrate that you have the tools available, you show the impact of the last several years worth of work where our coverage rates have gone way up, then you find enthusiastic support for the idea of a super fast track for kids, instead of targets just at 2020, targets by 2018. So there's extra attention in holding us and a whole lot of other people accountable for delivering in the next it's really the next 30 months. 6 months the rest of 2016, 2017, 2018. We have a whole bunch of work to do in that time period.
That's very ambitious.
Yeah, it is.
Chip mentioned the advocacy that went on to build these ambitious targets within the political declaration, which are based on, I think, a lot of work that faith communities have also done with other sectors. Bob, could you describe how the faith community has been involved in the work on children and the advocacy on children?
Well, I think faith communities realize that children don't have an organized voice as activists, as many other activist groups have had. And even starting from Durban in 2000, it was the activist community that insisted that we end the second-class citizenship of people in developing countries and make sure they had access to treatment. Children have not had that organized voice, and so the faith communities have tried to fill in with others in terms of trying to call attention to the lack of progress on getting access for children, as already Stuart and Chip have talked about. And one of the steps in this more recently, first of all, the Ecumenical Advocacy Alliance and Caritas Internationalis, the Confederation of Catholic Social Development Organizations, have had campaigns going to try to raise that awareness in the community. But then more recently, UNAIDS and PEPFAR approached the Vatican itself and said, can you use your moral, ethical, and convening power to bring together some of the key stakeholders that could unblock the obstacles that we face in getting access for children? The fact is that medicating children who are living with HIV is a difficult and complicated process. Children's bodies are not the same as adults' bodies, and we also still are lacking some of the needed formulations and dosages that are child-friendly, that are really focused on children. And so the president of the Vatican's Council for Justice and Peace, Cardinal Peter Turkson, agreed to work together with UNAIDS and PEPFAR to bring together some of these key stakeholders. And first of all, we had a very large meeting of people from the field in April, 3-day meeting at the Vatican's Pediatric Hospital to listen to the experience of those who are trying to bring treatment to children and to hear the challenges that they face. Immediately following that, we had a very small meeting with the heads of pharmaceutical companies and diagnostics companies, as well as people from governments, multilateral organizations in the UN and others, and then also people living with HIV. And to look at the specific challenges for children and see what it is we could do together, because no one sector of society can do this alone. Not governments, not the UN, not faith-based organizations, but together we might be able to do that, together with the private sector. And at that meeting we had a strong and intense dialogue with the companies. We had generic companies and big pharma, the R&D, the research and development companies, speaking to each other, sometimes for the first time, around these obstacles. And they expressed the interest and the commitment to work together to try to bring treatment to children on a universal basis, not just for a few children. They also made the point that we need collaboration from others. We need more research and development, and we need to make sure the funding is there. The companies recognized that this would not be a big profit-making venture, but they saw this as an imperative, an ethical imperative to save children's lives. After that first meeting at the Vatican, we reconvened the group 1 month later, again inside the Vatican's Pontifical Academies of Sciences, to try to move toward a more practical results. And at that meeting, we focused on 3 countries where we might do some pilot projects: Nigeria, Democratic Republic of Congo, and Zimbabwe. And the first 2, Nigeria and Democratic Republic of Congo, have had little progress in getting children on treatments. Zimbabwe has had more progress, but also the Minister of Health was with us and identified what continuing obstacles they face in Zimbabwe. So we moved to a plan to do this in 3 countries at first, and then see how we could expand to many more countries in the developing world. And that's the stage that we're at now, trying to get to a very concrete action plan to move forward with this, and to do it in a very short time span. As the head of PEPFAR, Ambassador Deborah Burke, said, we should take what we thought we were going to do in 2 or 3 years and bring it to a 6-month time frame.
Bob highlighted some of the treatment issues that are specific for children. I'm wondering, Astrid, whether you could lay those out. What are the special issues that are related to the medication and diagnostics?
I think first of all we have to see that when research and development is done for medicines, the companies always start with the adults. Then they move to the adolescents, and then at the very last they would research for the very young ones. And we've already heard, they are the ones who die very quickly if they're HIV positive and have no access to treatment. So it's very crucial that we have the medicines for the very young ones. But they were slow in coming. In the beginning we had only a few of the medicines that were used for adults, for children. So in many instances one had to maybe crush tablets for adults, or you could not use it at all because it wasn't it was not sure whether it was safe to use that particular antiretroviral drug for children. I think we've seen improvement there. We've also in the beginning and still in many countries, what is used for the very little ones is syrups, suspensions. So you have 3 different bottles with 3 different dosages, which makes it very difficult to give the medication to a child. And some of these suspensions need to be refrigerated, which obviously for a lot of resource poor settings is a challenge. So that was not a very ideal way of treating small ones. So the idea of having maybe dissolvable tablets that you can that dissolve in water would be a much better way, or little sprinkles that can be given with milk or with whatever. And so we've actually seen that a lot more options are open now, and a very, very important instrument was the Medicines Peyton Pool. The Medicines Peyton Pool was established in 2010 as a Swiss foundation. First of all, it restricted itself to HIV drugs. And it basically asked the originator companies to license their drugs to the pool so that generic companies could produce fixed dose combinations. And it has been quite successful with regard to pediatric formulations. We have all the pediatric ARVs that are recommended by the World Health Organization in the Peyton Pool now. And the geographic coverage of these licenses is 98-99% of the children who need them. And we know that obviously the majority live in Africa. So it's a good coverage, but it's not saying these medicines are where they're needed. I think we've laid the ground now for all of that. But we still, some of these fixed dose combinations are still being developed. And there's been a very, Bob mentioned these private-public partnerships as well, DNDi with Cipla, and I think Lyons is in it now as well. They are developing, for instance, one of, the first regimen you should give to a child contains this one ingredient that is very foul tasting. So obviously not the best thing to give to a little child. And so far it was a syrup. Now they're producing that as sprinkles. I think they still have a challenge masking that bad taste. I think that's still sort of a little bit of a problem now. But we can expect to have these sprinkles soon, and that will be a great formulation for little children. So I think we're making progress. We're not right there yet, but I think on the medicine side, we've really seen a lot of progress in the last few years. I think on the diagnostic side, we're not quite there yet. The problem with the diagnostics is that you cannot use the antibody tests you use in adults, because the baby carries the antibodies of the mother for 18 months. So if you do a test with the baby, it could give you a false result. So you need the virological tests. We know they're more expensive. They are available in many countries. We still have project partners that say we can't get them. So there's the access issue. The other issue is that these tests are usually used 6 weeks after the baby is born. Well, that means the mother or guardian has to come back with the child after 6 weeks. Now, many do not do that. So this is, as I think Stuart and Chip explained, not all the children are tested, because, they don't all come back for testing. And sometimes they also don't get the results. The child might be tested, you have to wait again to pick up the result. These are all hindrances to really knowing, is this child HIV positive or negative? And if it is HIV positive, we need to put the child on treatment as quickly as possible. So one important advocacy issue I think that still stands is we have to bring the diagnostics closer to birth. Soon after the child is born, it should be tested. And the present tests, from what I'm told, are 70 to 80% sensitive. So yes, they are producing some results, but they're not 100% accurate yet. So we need to really work on that. I think that we have these tests that can be used straight after birth, basically, and then we know, is this child HIV positive or negative? And then the child can be put in under treatment straight away. And I think that would save a lot of lives. Yeah.
Perhaps just to add on, the key element of that is that it's a point of care diagnostic. It's done at the clinic, as opposed to the result having to be sent to a centralised laboratory, which can take several weeks, and then getting the results back could also take several weeks. So
yes and no, I would say.
The key issue is that the mother doesn't get the baby tested on the spot, doesn't know the result, and whereas the point of care diagnostics that are now being tested in places like Zimbabwe that are making good progress, that's where these point of care diagnostics are available, but they need to be made much more available, more widely.
That's an issue. These machines, these little machines, they can run about 2 tests at a time. Now they cost at the moment between 30 and 50,000 US dollars. So they're not really affordable to roll out at this stage. Whereas, the big laboratory machines are of course much more expensive, but they can run hundreds of tests simultaneously. So there are also, interventions where the blood is taken to the central laboratory, but then the test results are, texted back to the mother directly or to the health center. There are now other ways, I think, of getting the results more quickly to the family, but maybe it might work out more economically to still use the laboratories. We probably need a combination of both. We need the big laboratories, we also need the point of care diagnostics.
So you mentioned one continuing advocacy issue, Chip, and you also mentioned the successful advocacy to strengthen the political declaration part on children. What other advocacy issues are out there for pediatric AIDS?
Well, there's several, and they're different audiences, but I'm concerned about what resources are being made available. There's a sense, to a certain degree, that the progress that we've been able to demonstrate over the last several years has allowed or led some people to conclude that there's enough momentum, it's in hand, we we can or we have to pay attention to other issues, or just the press of the emergencies. I mean, the world is really pretty rattled these days, and so whether it's migration issues, whether it's other disease outbreak issues, I'm concerned that there's either lack of attention, if not complacency, and it's translating into fewer resources, which would be perverse, frankly, if after years of investment. I mean, PEPFAR alone has invested $70 billion over the course of 15 years to fight this pandemic. We have made so much progress. We're at this point, but we have to keep going with the actions that have already been described. So advocacy, AIDS is not over. We have an opportunity, actually a historic public health opportunity, to end AIDS in children by 2020, but only if very specific things are done. And I think in virtually every country, we have to continue to push that it's not either or an emergency in Syria or an emergency disease outbreak or HIV and AIDS. We have to build health systems. We have to invest in the better health care in X number of, particularly the highest burden countries where our efforts are concentrated. So there's that as a major advocacy challenge, but Stuart and others will have notions of what else we need to keep visible.
Yeah, I mean, just a couple of other issues. I think one of the things that we've recognised is that we're not finding, in terms of, because we're recognising that many of the babies and infants are falling through the cracks, they are being picked up in the malnutrition clinics, in the sick child clinics, in the immunisation clinics. And so the important thing is that we need to be looking at other opportunities in maternal newborn child health and make sure that HIV and maternal newborn child health are really fully integrated, and that we're really trying to pick up those children who are found to be sickly in those other situations. So it's about trying to make sure that the overall system is strong and alert and aware to the issue of HIV. And related to that is one of the reasons why mothers and carers don't come bring their babies back is because of stigma. Stigma both within the community, if it's known that they or their babies are living with HIV, they are quite likely in some situations to not to disclose, and so not to come back. And more particularly in the context of certain health facilities, if health staff in those facilities are also stigmatizing the mothers and infants, then the mothers again are not going to be treated. Unless they're treated with respect and dignity, they are not going to come back. And so tackling stigma and discrimination, which I think is a real opportunity for faith leaders in communities, that's where we can really start to make a difference.
I'm going to have one more question, and then I'll open it up to see if others have questions as well. And this I would just ask of all of you, if you have a short response, is addressing children in the HIV response, is that the easy issue for the faith community? Bob.
I'll start out. No, it's not an easy issue, and I think we tried already to tell you some of the complicated mechanisms that we have to address in order to address the treatment access for children. So it's not easy, both scientifically, also in terms of the health systems work on it, and also, again, because the children don't have their own organized voice of advocacy. So I think, if anything, it's one of the harder issues to work on. And time after time, we've developed these initiatives at the global level to make sure we expand access, but children kind of fall off the priority list. So I think this is a very difficult issue that we've taken on, and I believe that we really need to work hard as faith communities, but also then we cannot do it alone. We really need to have an approach that involves all the key stakeholders if we want to succeed.
I think it depends in what sense you mean easy. You know, I would agree with Bob. We still have many obstacles to overcome, and I think, and it's a very important issue I think we're dealing with. It might be easy in the sense of it's not contentious. everyone would agree that children need to be put on treatment. I think there is not a person in the world that you would not get to agree to that statement. It might be, other groups that also need treatment. There might not be that consensus across the globe. So from that point of view, I'd say yes, it is an easier topic because because no one would say no. I think the money should go somewhere else. But if I just look at the figures, I must say I feel at the moment the group that's missing out are men. If we look at the access to testing, access to treatment, 49% of the children now have access to treatment. That is not enough because we know that the children die very quickly. So we definitely have to get that to 100%. But if I look at the men, the latest statistic from UNAIDS was that in Africa, 36% of the men have access to treatment. So the men are falling behind the children, And why is that? Because we do tend to focus on women and children. And I'm not saying that's the wrong focus, but I do think it's wrong to leave men out of the picture. And if we want to have more equal gender relationships, you simply cannot just work with women. And you have to talk about sexuality. You have to talk about some of the uncomfortable issues. But I think you also need to look at men's right to health for its own sake, and I don't see much of a debate on that. And yet we know, if you look at all the people who know their HIV status, 70% of them are women, only 30% of them are men. Men don't have the access to treatment and men die in much larger numbers of AIDS. So I think there we really have a gap, and obviously the key populations play a part in all the countries, And so I think these are probably the more contentious issues, but I tend to not play out one group against another. I think we need to make sure that children are on treatment, but I would like to see all the groups who need treatment to have access to treatment.
Any other short responses?
No, I really only to echo what Bob and Astrid have said. I have been just continue to be shocked over the 15 years I've been working this issue, how you think that issues about children, as you say, it should be non-contentious, and yet they always drop off the agenda. And the political declaration, as Chip was saying, the early drafts of that were really, there was very little mention of children. But and it was as a result of advocacy that we have fortunately got a much greater focus on children. But it doesn't happen because they're not vocal, and hence their issues fall off time and time and time again.
Last word. Are there any questions from those in the room or checking my emails?
I have a question.
So,
You may have already answered, but I can't hear it. I have to listen to the video later on to see what you said. But that's why the church? Why did it take Bob and the church to get involved in this in such a way, to intervene, to make this happen? Why couldn't it happen some other way?
Well, first of all, the churches have been involved in this for a long time, and many times reached out to the mothers and children, where others, even governments, didn't reach. So they've been involved already. But I think also faith-based organizations have a convening power and also stand for an ethical platform that others may fight, but they also listen to. And so I think that was the motivation behind UNAIDS and PEPFAR to approach the Vatican and say, can you help us with this? Not that they would do it by themselves. The other thing was that they saw the effect of Pope Francis's strong advocacy around the climate change compact. And in the document that he wrote, people think it was only on climate change, but it was really about integral human development. And he made the point in that document, Laudato Si, that no one group, no one sector in society can really bring about solutions for all these major complicated problems in the world. And he even mentioned pandemics as one of those problems. He said only by having people join together, the governments, the multilateral organizations, the churches, civil society in general, only by them joining together can we hope to solve problems like climate change or major pandemics. So he already had paved the way. And that was, I know, an inspiration to UNAIDS, because when the approach was made by UNAIDS, they pointed out that passage in Laudato Si and said, can you help us do the same thing on pediatric HIV that the Holy Father, Pope Francis, has done on the climate change approach?
Can I respond as well? If we've given the impression that things weren't happening before, that's not accurate. But what I think UNAIDS and others recognized from the great progress of the last 5 years, but also where there were still very serious gaps as it related to kids and being on treatment. And given the high mortality rates, and given the relationships, I mean, Bob has worked for 5 years in trying to advance the global plan, which has made great progress in terms of reducing new pediatric infections. I mean, there's a level of trust, there's a level of understanding, there's a sense 2016 was always going to be a really important year from a policy and political point of view. This high-level meeting at the UN, we've known about it for a while, was in June, the Durban conference now. And so I think there was a sense 4, 5, 6 months ago, 2016 is an unusually important opportunity. We better have our act together. We should be really clear about what the conditions are for kids, where and what we should be able to do differently to advance the agenda in favor of kids. And the faith community is an indispensable part of that. So it's evolved a little bit, recognizing the important political nature and policy opportunity of 2016.
Are there any sectors in the pharmaceutical industry that are sitting it out, that haven't gotten involved in this, that you'd like to see involved?
I don't think they're sitting it out. Everybody wants faster, better, cheaper in terms of drugs or diagnostics. But we work with pharmaceutical companies, the foundation that I work for. They're very good partners and have been for a long time. They want a cure, they want a vaccine. They'd like to be the ones that discover the cure and the vaccine for obvious reasons. But you may have, others may have a different impression, because the advocacy community sometimes has a tense relationship with the pharmaceutical companies or sector. But my impression is they're working as hard as they can in their environments to try and advance the agenda, better treatment, a cure, better diagnostics, and so on.
I think it changed when there was a policy change, I mean, obviously the pharmaceutical companies sit in the global north, and we know not many children live with HIV in the global north, so it was not very profitable to invest in, children's medicines for HIV. But when there was a policy change that when you bring out a new medicine, a medical substance, you also have to bring in a pediatric formulation. That in a way forced the companies, to get involved in that. I mean, even though it was clear it would not be a very profitable market for them. So, and that might have also sped up, I think, the licensing to the Peyton Pool, because for the better formulation, it is now the generic industry, and they obviously are based in India, in China, in Brazil, in other places where they're closer to the people for whom they will make the medicines. So I'd say it will be more the generic companies that will probably work on these formulations that are more appropriate for resource poor settings. But I think it was the policy legislation that has really forced the companies to also invest in pediatric formulations.
When you say policy, what organization?
I know that you cannot bring a medicine to the market without, you also have to tell them, when is the pediatric formulation going to come to the market. You can't just, say, well, forget about that one, we'll only do the adult one. So
they were incentivized.
Yeah.
I think, certainly what Astrid is saying is very, very accurate. Also, the Peyton Pool has been an important mechanism for companies, their R&D companies, to share their intellectual property rights in a way that's more fair and just. At the same time, some pharmaceutical companies have also privately worked with generic manufacturers to allow them to produce. And also the Peyton Pool is very important, but also there's been some delay in terms of getting to the action. They've now got the rights, but now getting companies to actually produce the medications, has been a slower process than some of us would have liked. So these are part of all of the complications. At the same time, when we were planning the meetings at the Vatican, we looked very carefully to include not only those companies that were producing pediatric antiretroviral medications, but also others that we felt we wanted to attract to. And we did invite them. They came. The same thing with diagnostic companies. One of the companies that's been the most active in these dialogues has been a company that's not producing anything right now in diagnostics, but is interested. And so, and sees the moral and ethical imperative of doing this. So I think we tried to reach out. We also reached out to some African manufacturers, and we had them at the table both times that we had these meetings. So I think we've tried to cover a wide range of involvement in this.
I want to thank you all very much for participating in this, for dealing with the challenges of the sound. We always have a very dynamic International AIDS Conference wherever we go. And thank you to all of you for participating in this press briefing. We have another one tomorrow with Archbishop Thabo Magoba, Dr. Luis Lores, of the Deputy Executive Director of UNAIDS, Ms. Sandy Thurman from the PEPFAR program, and Reverend Mike Schinemeyer from the United Church of Christ, to talk about the challenges and opportunities of faith-based response, particularly in collaborative efforts in HIV. So thank you very much, and look forward to seeing you later.
Thank you.
Thank you.
Thank you.